Good morning, everybody. It's bright and early. We're thrilled to have you here. My name is Ruth Bryant, and I'd like to get us started with our presentation this morning. I'm really excited to be able to share with you some of the results from the SEM Scanner technology. So today we're going to be talking about getting ready for a new world of pressure injury prevention using early detection technology. And we have quite a panel here that I'm sure you're going to enjoy their presentations as well. So in terms of full disclosure, the speakers for this presentation do have an honorarium from BBI, from Bruin Biometrics. And the clinical data that will be reported in this presentation, of course, was supported by BBI. The work that we're presenting is our own views and opinions, however. And the SEM scanner that we'll be talking about is pending FDA decision. It's not for sale yet in the United States. So just to upfront introduce you to our speakers, Amit Gefen will be speaking with you. If you haven't had a chance to hear him, you're going to enjoy his presentation. He has his PhD and is a professor in biomedical engineering, and will talk to us all about how the tissue deformation is a critical piece of what is going on with pressure-related injury. And Tom O'Connor is speaking to us about his clinical experience in utilizing and applying this kind of technology in his practice. He's got extensive research in the clinical setting. And Jeanette is an established tissue viability nurse, has been in the field, she says, for 20 years. Sorry, Jeanette. And has extensive experience both in the community setting as well as acute care. So she'll be talking to us about her experience using this device. And then I am currently the Director of Nursing Research at Abbott Northwestern Hospital in Minneapolis, and have a few more years than Jeanette in wound care, sadly. So we're thrilled to be here to present for you. And I'd like to have Martin come up at this point just to talk to you a little bit about the company itself.
Morning, everybody. It's Vegas. It's 7 o'clock in the morning, and you're all here. Well done. That's really rather remarkable. I got up this morning, and it was still dark. I was thinking, my God, the last time I was in Vegas, and it was still dark. At this time in the morning, I was coming in, not going out. So anyway, thank you very much for being here. Thank you also to our speakers, and to Amit, he's here right here. We're very pleased to be here. Let me just give you a very quick two-slide view on the company. BBI was founded in 2009. We licensed technology from UCLA, which is the University of California in Los Angeles. And the goal was to try and identify technologies that would make the stated target of prevention of preventable conditions real. And so what we did was we licensed out this technology, we developed it. The SEM Scanner is the lead technology. We have several others in our portfolio. I'm delighted to say that because of the work that we've been doing in Europe in the last 3 years, that we last year won the Patient Safety Award in the UK. We went up against 550 companies, and we were the ones selected for the most innovative patient safety product in the UK. It's being used. It works really well in clinical practice, only when nurses act on the data. So the primacy and the fundamental role that nurses have still remains, and we're there to try and support them. Okay, so let me just very quickly set this up. To get from an invention all the way through to a technology that nurses can actually use, we had to gather an enormous amount of data, primary data. There were 4 types of data. Type 1 is bench data. You have to make sure the device actually works and you can demonstrate that it works. We did that in the lab. Secondarily, there are formal clinical controlled trials that are blinded. These are the things that are controlled by the Code of Federal Regulations and those ISO standards. They are incredibly rigorous. We as a company do not get access to the data until the data is imputed and locked. We don't ever get to see it. All the statistical analysis plans are designed up front. So it's about as rigorous as you can get. And there was 3 of those, slightly less than 400 subjects. They built on each other, and you're going to hear them being talked about today. Then, we've been very fortunate to partner with the Royal College of Surgeons in Ireland, and Tom, who flew a bit more than 6,000 miles to get here through the snow, will be talking about those studies. We don't get to see the protocols, we don't get to see the data. Those are independent from BBI, and they truly are independent. And then finally, we like to look at what nurses actually do in clinical practice, which is what we refer to as real-world data. We go in, we train, and then we leave. It's a bit like when you send your kids off to stay at an overnight camp, and they sort of put on their very, very best behavior. Those are the sort of BBI clinical studies when they do the very best behavior, all their manners come out, and you think, okay, great, that's a lovely kid. And then they come home, and then they actually behave the way they normally are. That's the real world study. When they kind of, don't brush their teeth and don't flush the toilet, that's what the real world studies are. And we've done all of those, and there's actually in the database, there's about 1,000 subjects. We'll talk a little bit about the 632 subjects here. So with that, let me pass over to, who's going first? Oh, last thing, can I just say to the speakers, I've already said thank you, but I'm going to say it again. Thank you for flying all the way from Israel, from Dublin, from the northeast of England. Ruth, I don't know where you are actually, so I don't know how you flew. Yeah, right. So you probably had the hardest journey of the lot, but they collectively has flown over 20,000 miles to get here. And I very, very much appreciate it on behalf of the company. So thank you.
So our sequence will be the different presentations. We'll have Dr. Gefen speaking first about the etiology, pressure injuries, and the need to assess early signs of cell damage. And then we'll proceed to having Tom present on a novel technology for the objective and quantitative early PI detection. And you should have all this kind of information in your packets. And then I'll speak on the technology versus visual skin assessment in the clinical setting. And then Jeanette is going to talk about translating risk assessment of early detection into technology into clinical practice. So we're going to give you the full picture of what we see right now and what is going on, transpiring. So I want to remind you in your packets you do have a pen and paper, and welcome Dr. Gefen.
Thank you, Ruth, and thank you to all of you for joining us in this early hour. I'm going to present the latest knowledge that we have on the pathophysiology of pressure injuries and how that pathophysiology connects to what the SEM Scanner is actually measuring. It all starts with the fact that we apply body weight forces constantly on our tissues and our cells. And as we do that, our tissues and cells are constantly distorted and deformed. And not only that the cells are deformed, as they are deforming right now when you're sitting on your buttocks tissues, the intracellular structures, the structures within the cells, are deforming and are distorted. And as we say in biomechanics, structure influences function. And if you change the structure, you may alter function. And for studying the relationship between the shape or the structure of cells as they are distorted and the biological and physiological function of cells and tissues, over the years, we have developed multiple model systems, which we call living model systems. And these living model systems look across the different scales of the human body, dimensional scales. They look at how the whole body behaves, such as in MRI studies, which directly demonstrate tissue distortion, in this case in the buttocks, just under the ischial tuberosity. We look at animal models which demonstrate how tissues respond to mechanical loading and may die as a result of excessive exposure to mechanical loading. But we also look microscopically using tissue engineering methods, where we grow pieces of living tissue in culture dishes and examine the intercell processes and the cells as these tissue constructs are being deformed and distorted. And we also look at the individual cells, which we also are subjecting to mechanical forces and deformations. And all of these model systems, essentially this slide is presenting 20 years of work or so. All of these model systems together indicate that it is the exposure to the sustained tissue deformations which is the primary cause for cell damage and eventually cell death. And how does that happen? Well, already in the Spanish Inquisition, they knew that if you apply excessive forces on a living body, the skeleton breaks down. And it's not only that human bodies have skeletons, cells have skeletons too. And these are called cytoskeletons. And these cytoskeletons are supporting the cell walls, much like in a structure where the foundations and the beams are supporting the walls. The skeleton of the cell is supporting the wall of the cell, which is called the plasma membrane. And as these cells in your body are distorted and deformed, their skeleton starts to break down, and eventually there's not enough support for the walls of the cells, and then the walls of the cells become perforated, so little holes or pores are forming at the plasma membranes of the cells, and through these pores or holes, everything essentially can go through, and everything can escape. So the cell is losing its homeostasis, its biological equilibrium, by losing the control of what goes in and what goes out, which is normally well controlled in cells. If we were traditionally trained or educated to think about ischemia as the primary factor causing tissue damage and cell death, well, ischemia is also one result, one derivative of deformation, because as deformation is affecting cells, it's also, as a byproduct if you wish, it's also constraining, deforming, distorting the vasculature, which as a result are obstructed or maybe even sometimes locally occluded. But that's just one factor in the spectrum of effects of deformations. And importantly, as we understand that deformation is a cell killer, we need to also understand what the timescales are. And we know from these different model systems that I have presented that deformation damage, which is only affecting the vasculature, that is ischemic damage, takes hours to develop. Whereas the breakdown of the skeleton of the cells resulting in the loss of biological equilibrium and cell death as a direct result of deformation without the effects of ischemia takes only minutes to develop. So the time scale for developing deformation-related damage is much faster than the time scale for developing ischemic damage, which is why we need to focus on the primary cause, which is the deformation, to protect tissues and the cells within. But what happens if an injury starts to form? What happens when the first cells die? When the first cells die, as a natural mechanism in the human body, they release signaling molecules. They release signaling molecules that are targeted at immune system cells. They basically call these immune system cells saying, please help us, we're dying. If you can't do anything else, just clear up the mess of the debris of these dead cells or dying cells. So these immune system cells, which are in the vasculature, they're in the bloodstream, need to go out there, find those dead cells or dying cells, and act upon them. But in order to do that, they need to cross the barrier of the vascular wall because they're in the bloodstream. How do they do that? Well, the same signaling molecules, which are called chemokines, are affecting that structure of the walls of the blood vessels, and basically they make them spread a little bit to create these little gaps through which the immune system cells can crawl out and reach the target. But as that happens, the vessels also become leaky. The walls become more permeable. And that's why we have edema, because fluids start to, basically plasma from the blood flow, start to accumulate in the tissue. And that's a gradual process. It builds up microscopically and accumulates into bigger and bigger volumes of fluids, and eventually you see that swelling, which is clinically known as edema. But what if we could detect these early inflammatory reactions, this early inflammatory response, and detect the changes in the fluid contents of the tissues where the damage is happening? And this is essentially what the SEM scanner is doing. It's measuring localized edema, which is called subepidermal moisture. And that subepidermal moisture is essentially building up over time as the inflammatory response is triggered. Eventually, as I said, it will accumulate into a massive edema, but we want to detect that much earlier in the process, at the point where it might be reversible, where it perhaps can be reversed by the body repairing the micro damage. So subepidermal moisture is essentially this localized edema which cannot be detected through visual skin assessment. Once you see something on the skin, it's obviously too late. And how is the device doing that? It's intended to measure the electrical capacitance or biocapacitance because it's tissues. And you've all seen capacitors in the past, even if you're not electronic engineers, because capacitors are everywhere. And capacitors are essentially accumulating electrical charge, and the electrical charge depends on the properties, the material properties of the capacitor. But the material properties of the capacitor depend on the volume contents. So if the capacitor is a tissue, which is our case, if you accumulate fluids within the tissues, you increase the capacitance property. So as these fluids accumulate in the extracellular space, capacitance increases. And that's what the device is essentially detecting. So when there is high fluid content in the tissue, but still at the microscopic level, you would get a high reading, where when there is no fluid, that is, there is no localized edema, the reading would be low and hence normal. So as edema builds up, again, SEM values rise. Now we know that most of the serious pressure ulcers occur internally. They develop internally. Now we call them deep tissue injuries. And sometimes these deep tissue injuries present themselves on the skin when the skin is still intact, and sometimes it's eventually all breaking down, and we see these big craters, which are the stage 3 and the stage 4 pressure ulcers. We know from all the biomechanics work that we have been doing that the injury starts internally, and if it starts internally, when you detect something on the skin, it's really too late, because there is massive tissue damage, massive necrotic tissue which is already there. You actually want to detect earlier. So what makes a good detection? Or in more general terms, what makes a good medical measurement? In a broader context, it needs to have 3 criteria which are met. It needs to be objective. It needs to be standardized. That is, if someone else is measuring something and I go and do the same measurement, I get the same result. And it needs to be quantitative. So provide a number as opposed to qualitative evaluation. Visual skin assessment, which is the usual care, is being more of a documentation than detection for the reasons that I've just mentioned. Once you see something, it's too late already. It's certainly not objective, it's certainly not standardized, and it's certainly not quantitative. Ultrasound, which is a technology-aided assessment, because it provides you not only with information on what happens on the skin, but also with information on what happens below the skin, suffers the same drawbacks, essentially. It's not objective. It may well change between two different ultrasound operators. It's not standardized. It depends on the technique where you're taking the ultrasound images. And again, it's not quantitative. What the SEM technology is offering is essentially a leap forward in medical technologies in this field of wound care, in the sense that it's both objective, standardized, and it's also quantitative. So it meets essentially the three criteria. And to me, the most important thing is that at last it brings dedicated specific technology to the field to allow for risk assessment and early detection that are informing the clinician of the real tissue health status, not only on the skin when it may be too late, but also internally, inside, where it may still be reversible. So can you imagine a world without medical technology in, say, cardiac monitoring? No ECGs, no blood pressure monitors? Should we compromise on low tech in wound care? You should ask yourself these questions. There is a lot of clinical evidence in the literature which I'm not going to cover today, but it's all out there published. Most of it by my very good friend and colleague, Professor Barbara Bates Jensen from University of California at Los Angeles. They looked at different settings, nursing home settings. There's also studies in spinal cord injury settings, residential care settings. It's constantly showing that the SEM scanner provides that early detection, typically 5 to 7 days prior to a pathological finding in a visual skin assessment. And it shows the potential in both risk assessment and early detection. And you can go, and you should go and search for the literature. I want to just briefly, very briefly show you one study in which I was involved, where we've compared all these different means, the usual care, the ultrasound, and the SEM, in a small cohort of 15 patients, but we did detect one DTI which has formed during the course of the study, which was 15 days. For one patient, the SEM scanner reading was abnormal at day 2. For the same patient, the ultrasound detected a pathology a day later, which is a lot in terms of how fast these injuries evolve. And the visual skin assessment was only positive at day 5. So that clearly shows that time course of where these tools, different tools, become sensitive to the existence of cell and tissue damage. And that's why I see a lot of potential for the SEM scanner device in early detection. And I'll conclude here by summarizing the important points that I was trying to convey today. Sustained body weight deformations do cause cell and tissue damage. The damage happens rapidly and silently under the skin. Edema, which is a part of a normal inflammatory response, would be an early marker, especially if you target the localized microscopic edema before it becomes macroscopic. Early detection is critical for reversibility of the condition. Early detection is fundamentally different than visual skin visual skin assessment, because visual skin assessment is post-mortem. You're documenting damage which is already there, whereas in early detection, you may have a reasonable chance to save those tissues, which is why that plugs in very nicely with prevention, which is, as we all agree, I'm sure, is the way forward. Thank you, and I let Ruth present the next speaker.
Thank you, Amit. So, good morning. And like everyone else, it's great to be up so early in Vegas. It's my first time in Vegas, and I've sort of realized that going to bed and getting up is sort of relative terms here. People just seem to do that at all sorts of different times, so I don't think it's that strange to be up this early. So, as Ruth and Amit have said, my name is Tom O'Connor. I'm from the Royal College of Surgeons in Ireland, the School of Nursing and Midwifery and the Royal College of Surgeons in Ireland. The Royal College of Surgeons sounds very grand. I'm not royalty, I can assure you. It's a historical college that was set up in the 1700s alongside colleges in the UK, such as Edinburgh and London, essentially to look after the needs of surgeons at that time. But since that time, we are now a health sciences university. And myself and my colleagues here in the School of Nursing and Midwifery, we work primarily in nursing research and wound management, tissue viability, and some of the characters you see here on the screen are all my colleagues who are working in this area. So, as Martin has mentioned, the area that I'm going to just talk about briefly are the studies that we have been involved in using the SEM Scanner. So we've been using the SEM Scanner since for about 4 years now in a range of clinical studies. And these are, if you like, the sort of the real world studies. These are the ones that are out there with patients. We're actually using it in practice in a variety of different settings, as you'll see. So I'm going to talk about using SEM and pressure ulcers, the current data, and some of the clinical impact. So I'm just going to start with this slide, and this is a very busy slide. I know it might be a wee bit offensive to the eye, Amit has covered all of this really in detail and with far more eloquence and authority than I ever could. But I think it's just important to note that at the top of the slide here is, as nurses, here's the area that we're sort of most comfortable with. Okay, this is the one that we know. This is what we've always done. We've looked for visual signs of tissue damage. We've responded to that and classified that and staged that and made judgment calls on that, and we've looked for all those classic signs of inflammation and all those sorts of things. So, but what we understand particularly from Amit and from people like him, is that when you get mechanical load in underneath, down below the tissue where we can't see, we have all these sorts of processes taking place. Okay, as Amit has talked about, you've got all sorts of ischemia, leading to all sorts of problems in various areas, and eventually coming to a point where the cells, through the pressure that's put on them, are starting to come under pressure and actually die and cause problems. And in that process, then we get this release of moisture into the spaces that can be measured. So if you think about it, currently where we start to detect this is up here, okay? But we know now that all these processes, and we have known for some time that these processes are taking place in underneath, okay? So really what the SEM Scanner allows us to do, we think, is it allows us to get to that point where we can actually see that there's a problem, that something is actually developing before we can actually see it on the tissue. Okay, so it's allowing us to look, if you like, in underneath the skin at the processes that we know are taking place, and it gives us a tool in that regard. So the clinical studies that we've been doing, the first study was, if you like, it was a desk study. So what we did is we did a systematic review to look at the value of measuring SEM and other technologies like ultrasound and photography and thermography to see what the value is in using these. So this is a study that's published in the Journal of Wound Care. Free to go and have a look at it. So with regards to SEM and pressure ulcers, what we see in that is there are 4 studies that were included in this systematic review. So pressure ulcer incidence rates varied between 24 and 46% in these studies. There were 80 stage 2 or more pressure ulcers developed across the studies. And all the studies showed that skin damage and higher PU rates were associated with high SEM delta measures, so that there was higher SEMs where there were pressure ulcers. So once the SEM delta value was elevated, this predicted visual pressure ulcer development a week later. So the next study then was we had a number of smaller studies, and we're working towards some bigger studies now. And in this study, we had 29 patients, majority of them female, an older population. So these were followed up for 4 weeks. And during that 4 weeks, we measured SEM, and we also had Waterlow and Braden and visual skin assessment going on. So what we saw principally in this study was, you see it on the left-hand side on the graph there, throughout the duration of the study, the Waterlow and the Braden scores didn't alter at all. I know you use Braden mainly here. We use Waterlow. We tend to use Waterlow more in UK and Ireland. So there was no change. Those scores weren't telling us that anything was happening with these patients. If we were just to look at those, we'd say, well, everything is fine. But what we saw in that time was that the SEM readings were vastly varying right across that time, okay? So the SEM scanner was alerting us to the fact that there's something going on, whereas the Braden and the Waterlow scores didn't tell us anything at all. They remained constants, okay? So there were actually 3 patients who developed pressure ulcers visually during the course of that study, given a pressure rate incidence of 9.5%. But we had more patients who had elevated SEM readings at that time. Then the next study was a study that was in an acute care setting, principally in a surgical setting. So again, smallish cohort of patients, 31 patients, short stay surgery. So this was, relatively speaking, a quite young, much more younger cohort than we had in the previous study. So these were, in the main, these were young, healthy people, if you like, who would come in for short-term surgery. So what we saw in this study was visual assessment. There were some pressure ulcers, so we had a 6% prevalence rate of pressure ulcers in this. But the SEM scanner, the readings that we took with that indicated a prevalence rate of 42%. So much, much higher. Okay, so 7 times as much. And also what we saw in this study, which was interesting and which you'll see we've used in subsequent studies. So when these patients came in, largely you see their SEM, if you like, their SEM readings at the start of the study, before they went to surgery, were low. And then on day 2, typically was their first day post-op, all their SEM readings in general went up, okay? This corresponded with their immobility, okay? So as immobility went up, SEM readings went up. Now, what happens here is then most of these people get up and walk away. So that isn't a problem, really, okay? So SEM readings are going back down, immobility is decreasing, i.e. they're getting up and walking away, so there isn't a problem. But what it does alert us to the fact is that this early pressure damage is happening here in the surgical context. And it's not a place, I suppose, traditionally, certainly, it's not an area that we would have looked at before and thought about in terms of pressure ulcers. The third study then looked at the relationship between nurses' visual assessment of the skin and subepidermal moisture measurement. This was carried out in acute care, mainly with older adults, 47 in this, mainly female. As you can see there, the mean age, again, these were mainly older people. And what we saw in this study was that we had a 34%, or 16 out of 47, developed 18 signs of pressure ulcer damage visually. Okay, so the mean number of days for nurses to detect the damage themselves, i.e. through visual assessment as we would traditionally do was 5. Okay, so it took them 5 days to actually, before they actually saw the physical signs of damage. Whereas in all of these patients, they all had elevated SEMs, and that was typically at 1.1 days. Okay, so on average, that's 3.9 days earlier than the nurses were actually picking it up and seeing it themselves. Okay, so you can see here in this study, this is alertness to the fact that the SEM scanner is picking the damage up a lot more quickly than we would do in the traditional means. So, and what you see, the graph on the bottom there just shows the mean SEM values, which are both the damage threshold, which is 0.5, right the way across the board for the 18 patients who did go on to develop visual pressure ulcers. We then did a secondary analysis of those first 3 studies, and we just did some number crunching on the results of those and put some of those together to see what it come up with. So what we found in terms of incidence rate comparisons there, from using the visual assessment, so we had 38 pressure ulcers using the SEM delta values, that goes to 54, so a lot more. We also correlated then the SEM delta values with visual skin assessment scores to see was there a relationship between them, and there was. They correlated. So it leads us to believe again that these two things are linked and that there is a relationship there. And also then we correlated mobility and SEM delta values, because we believe that mobility, as you all know, it was one of the primary risk factors in terms of pressure ulcers. So we looked at that, and again we saw correlations there. So our conclusions from that were that SEM indicates a higher incidence of pressure rate of detection of pressure ulcers than visual assessment. There's a moderate to strong correlation between the SEM delta values and visual assessment scores on all 3 anatomical sites, so in this case the heels and the sacrum, suggesting that SEM measurement is a reliable manner of detecting early pressure damage in a clinical setting. And the negative correlations then between SEM delta values and the mobility scores shows that decreased patient mobility corresponded with the rise in SEM delta values, again suggesting that SEM is capturing this primary risk factor. So the next 2 studies are studies that are still ongoing. So these are larger studies that we're now working on. So the data from these is not complete. So what I'm presenting here is just sort of an initial look at some of the data that we have in this. So in this 5th study, it's looking at pressure ulcer risk assessment, risk factors, risk screening in older persons. So this is in what we would call a care of the older person setting in Ireland. So this is looking at a range of data and a range of risk factors, and one of those then using the SEM scanner to see what we can do. The principal thing that we're looking at here is mobility again, and we're looking to see is there a relationship between mobility and the development of pressure ulcers. So in this study we have these patients in a lot of cases are quite often bedbound. There's a mobility scanner in underneath in their mattress in the bed, which monitors all their movements, and we've got a huge amount of data because it actually tells us every second how much someone is moving in the bed. Okay, so you can imagine if someone's in bed for quite a long time, we follow them up over 20 days. You can imagine how many readings you're going to have on that. And we're also then taking their SEM readings to see what's happening there. So what we see here is that SEM delta scores of movement readings vary, reflecting changes in the patient's actual movements and responses to pressure and shear forces. So you see on the 2 graphs here, what happens is, for example, in this area where mobility is decreased, again, SEM values are going up. Okay, so it's responding to that change in the patient's status. Okay, so you're getting a response from SEM in that way. And in this initial, as I said, it's quite a bigger study, there's 150 people in it, and we've only done really a sort of an analysis of about 20 or 25 of them properly yet in terms of the data that we have. So we had 2 pressure ulcers to develop in individuals where there was very little movement. Okay, so you'd say, yeah, okay, we'd expect to see that. People who are not moving a lot are obviously more at risk of developing pressure ulcers. But we also saw pressure ulcer development in 3 people who were moving a lot. In fact, we were calling them the high movers. Okay, so we ended up in this study. What we're coming to the conclusion, as I said, this is an early analysis, that we have 3 types of movers. We have these low movers, and their SEMs are elevated, and that makes sense to us. we have the normal movers, okay? They don't have elevated SEM values. So again, that makes sense to us. But then we have these high movers, and they're exhibiting a lot of signs of movement right the way out through the day and night. And they also had elevated SEM delta values. So our hypothesis so far is that low movers, yes, pressure, shear forces, the loading, absolutely. That's leading to pressure ulcer development in these patients with the types of interventions that we expect to see, or we would put in place for those. We are hypothesizing though that there are also these people who are what we call these high movers, who may be agitated or may have conditions or neurological conditions which is contributing towards their movement, and that perhaps this is more in relation to the shear forces rather than the pressure. And we think that maybe we need to look at that cohort of patients differently and think about the interventions that we might put in place with them. And then the sixth study and last study, again, as I said, this is an initial look at this because this is an ongoing study. So this study is looking specifically at the role of subepidermal moisture medicine versus traditional risk assessment in the prediction of pressure ulcers amongst adults undergoing surgery. So in the first smaller study that we did that looked at surgery, we thought, okay, this is something that we need to look at in more detail. So we have a far bigger cohort of patients now in this study, 162 altogether. We're collecting a lot of data with respect to their status during surgery, what type of anesthetic they had, how long they were in surgery, how long was they actually in the sort of whole perioperative environment, and we're following them up over 3 days essentially while they're in surgery. So what we're seeing here again in this is that on day 0, preoperatively, SEM readings are done, okay, indicating any problems. There was about 10% of people had higher SEM readings at that time, okay. And then on day 1, first day post-op, what we're seeing is that 90% of this initial look at the data actually had elevated SEM readings, okay. And then you see again, like we saw in the last one, on day 2 and day 3, as they get up and walk away essentially, or as they start to mobilize again after their surgeries, their SEM values then go down again, okay? But the big thing for this is what happens if they don't get up and walk away? What happens if they remain to be immobile, have complications, whatever it is? We have to understand that the pressure damage has taken place right back when they were in theatre, okay? And nobody's thinking about that, or nobody's doing anything about that at that time. So it's led us to look at this, think about this differently in terms of our surgical patients. And we saw this in various areas: elbows, heels, sacrum, okay? So these were all areas that were apparent. This slide here is data that's not our data. It's data that was done in the UK, that was carried out mainly in the UK and in Canada. And it just shows the effectiveness of using the SEM scanner in terms of decreasing the hospital-acquired pressure ulcer rates. So you can see there, 50% of the hospitals, nurses observed 0 pressure ulcers during the evaluation period. An additional 2 hospitals observed reductions ranging from 87 to 90%. So in this way, the SEM scanner was effective. So what we have at the minute is a lot of data, okay? Some of you who know my colleague Zena Moore will recognize her with her curly red hair, okay? So we have this pool of that's me there, but my bad hair day. So we have this pool of data now that's developing, and we're really, jumping in there. And as you can see, we're working in a number of different areas, different types of patients. I mean, we'd love to, apply this in a whole range of different contexts to see what sort of results we're going to get. But we're really at the point now of getting into the data and getting stuck into it. So, conclusion for us is the ability to assess going underneath the skin, out of sight of visual assessments, offers a chance to intervene more quickly and effectively to minimize the damage. And using the SEM scanner provides clinicians with an objective measure with which to work. So something that we can actually measure and quantify and we can work with. Thank you very much.
So I'm going to talk to you about my experience in this clinical trial I had the privilege of participating in while I was at Providence Sacred Heart Medical Center in Spokane. And so take the information they've presented and make it really clinically relevant so I can show you what we did. So this is a multi-site study. There's a pivotal clinical study that we had participated in. So at this point, we are looking at a study comparing, looking at the patient population and looking at what visual skin assessment looks like compared to the SEM measurement. So we're getting more of the data for the validity of this tool. And this was a longitudinal study that was, the objective was to evaluate the use of SEM Scanner as an adjunct to clinical judgment for the early detection of pressure injuries in patients before clinical judgment using visual skin assessment. And you know, when you're trying to develop a tool, you have to compare that to something that's a valid gold standard. And so the question was, what is that valid gold standard? Because, you know, that, and then at the same time, when you're designing your study, there's several things you have to consider. One is you can't withhold care. And we know that patients need, you know, if you're thinking somebody's at risk, there's interventions you have to put in place to prevent that risk. So, and we knew that there was a lot of different interventions people could use. So the design had to accommodate what is the gold standard, what are we going to use for that, and it had to accommodate the ability for the clinician to interject their expert opinion as to what appropriate care would be. So it's not a study that you could actually randomize people to, obviously. So how the study was designed at the different sites is that it was multi-site, it was prospective, and what was done is that you had two kind of experts involved. One expert would assess the patient and do the visual skin assessment. That was our gold standard. The other person would actually take the SEM scanner and do a measurement. The two people did not talk to each other, did not share their assessments, did not share any information. The person who was doing the SEM scanner was not privy to knowing anything about the skin condition, the interpretation from the visual skin assessment at all. And that person who did the visual skin assessment then would record that, and then again, the clinician, an expert clinician, could come in and make assessments, could come in and make determinations on different interventions that should be done to help if they observed or saw a problem that they wanted to intervene with. So we had the generalist doing the scanning and the wound care specialist doing the visual skin assessment. And when the definition of detection is the SEM scanner, a positive detection is the SEM delta, the difference score, that's greater than 0.6, and that had to occur for 2 of 3 consecutive days. So it wasn't just a one-time measurement. These patients were enrolled for several days. I think it was like 2 or 3 weeks. And they, as soon as they developed a pressure ulcer, then they would, you know, drop out of the study. Their study was complete. And people were surprised that you actually could have patients that long. In our acute care setting, we had patients in there for a long time. We had a lot of intensive care-based patients who were at high risk. So it was not hard to get those lengths of stay. But this study, being multi-site, also included not just acute care, but also community dwelling or the skilled care facilities. So this just shows the number of different sites and the different numbers of people that were enrolled from those different sites. It was across the United States and UK. So when we look at the population, we had a total of 189 subjects, and 7 had to be removed from the study for different reasons. Initially, people were recording the data inaccurately. They were recording the difference instead of the actual measure itself. So those had to be deleted. And so there was just in getting used to the study, there were some errors made along the way early on. But you can see the population is pretty equally divided between females and males. And of course, it was, you know, as in our population was pretty much a Caucasian population, although there was, you know, a fourth of them or at least are Asian with a little darker skin tone. And the BMI was pretty comparable between females and males. Age range, you know, 79, 73. And so let's see. So this just shows you again how the patients rated in terms of their severity. So you can see they were high risk. These were sick people. So if we look just at the Braden score, I think you're seeing my pointer, maybe you're not, nope. So if you look just at the Braden score, probably about 80% of them were at very high risk, and moderate risk. So we weren't taking, people who weren't at risk. And so you could see that these people were vulnerable patient population. The inclusion criteria were that they were older than 55, at risk of developing a pressure injury, as determined by their scores. And what we excluded with anything that was any patient that had unhealed pressure injury at any anatomical site, if they had broken skin, so it could be IAD, MASD, we excluded them from the study. And the study involved measuring at the heel as well as the sacrum. So those were the sites that we looked at. Pressure injuries developed in 48 of the intended to treat patient population. And you can see here the breakdown for whether, for the all population, whether it's sacrum and heels. You can see that, 66% of them were stage 1s that were detected. The sacrum and heels, 25% were detected as stage 1. But then what's interesting is you look down at the heels, that 20%, almost 21% were detected as SDTI when they were classified. So this is an interesting slide to help point out how the SEM scanner actually compares to visual skin assessment. And let's see. Oh, well, I can't get that to go, so that's just me. Whoops. So the A line is the line of agreement. So that's where if the visual assessment and the scanner both detected tissue damage, that's in the line of agreement. The B indicates that the visual skin assessment was actually, in that case, occurred on day 3. And so the visual skin assessment actually picked up faster than the scanner picked up. And then if you go up to C, you can see that the SEM scanner was 2 days faster than the VSA. So if you follow the lines, you can see the SEM scanner picked it up on day 1. The SEM scanner is along the bottom line, and the visual skin assessment is along the the vertical line. So you can see that the SEM scanner picked it up on day 1, while the visual assessment wasn't until day 3, so it picked it up sooner. So those were the kinds of things we wanted to compare, how soon one was detected over the other. And this shows then, using that same diagram, when you look at just the heels on your left, that you can see on day 1, the SEM scanner picked up several patients with detection of fluid or edema, subepidermal moisture, but it took several days for the clinical visit the clinical assessment to actually pick that up. So for the might be day 1 for the SEM scanner, day 4 for the clinician visit, day 6, day 7, day 8. So you can see how that varied across the time, and that was on the heels. And if you look over at the sacrum, then again the same thing was occurring. There was one SEM scanner that was, the visual assessment occurred in advance of the SEM scanner. So you can see the earlier detection that was going on with the SEM scanner, which is actually very encouraging, because if you think about how we detect sepsis or patients who have UTIs, we have really good clinical markers to detect those, while with that are very objective. While with pressure ulcers, we don't have that luxury. So this is pretty exciting to think that we might detect some damage early on. I like to show this slide. It has several different lines to it, and really what is important is if each one shows the 10 heels, and it shows the measures that occurred over time. And so you can see they are low, and then they curve around. But the one you want to pay attention to is the black line with the black triangles, and that's the average of all the scores. And so you can see that initially that SEM reading was low and then gradually increased. That line, at 0, that is when the actual discovery occurred, when they would see that. So you could see as the visual assessment line becomes closer, that SEM score actually increases on average, getting closer to the actual day of discovery. So not exactly sure how that would be interpreted clinically, except when you think back about Moore's diagram showing tissue damage and all the different factors that are transpiring. You know, it's not just the deformation, but it's also the nutritional complications that occur at the cellular level, the oxidative injury that's occurring. So you could think that all that is accumulating and maybe contributing to this increasing subepidermal moisture condition. So if we think of the patients who were receiving care and detecting their visually or by the SEM scanner detecting the pressure, we wanted to make sure that patients were getting the kind of care they needed. And this just shows you that, in fact, almost 90% of the patients were getting the care that the clinician was recommending for their care, and yet they would go on and develop pressure ulcers. So I think that really speaks to how even in our best intent, we're still missing people who are getting pressure ulcers. So these people had the support systems, they had heel offloading, they had the repositioning going on. So in conclusion, we know that biological and chemical processes are going on underneath the skin surface. That's what this is really helping us to see, the hypoxia, ischemia, and we can't see that with the naked eye. And the data from this study suggests that the SEM scanner is intended to be a leading indicator, so an early detector of pressure-induced tissue damage. And so the early detection before skin breakdown is like, you know, that would really allow us to intervene more aggressively to actually reverse damage potentially, as well as prevent damage. So we might be able to really intervene and address some of these problems in a much sooner fashion. So thank you very much.
I'd like to thank BBI for inviting me. I come from a small area in the north of England, 110 miles south of Edinburgh, called Newcastle upon Tyne. Probably the only thing that we have exported to the US is Newcastle Brown Ale. I haven't seen it in Vegas. My other speakers have given me 3 minutes to do my slides, but I will do my very best to skip through some of the previous data, not to minimise what they have said, of course. These are my declarations, but the work presented here is my thoughts. We obviously, and I congratulate you, you wouldn't get any UK nurses up at 7:15 in the morning. You know, that just wouldn't happen. Even if breakfast was being served, we wouldn't get that. What we know is what we're living through. You know, I am a tissue viability nurse and, as Ruth said, 20 years in the field, but the population is ageing. The international agenda to reduce pressure ulcers is a laudable agenda. However, we only know what we know. And I would argue that we haven't really reduced overall numbers in the UK. We're good at looking at skin and implementing blanket programs. As Ruth said, we implement blanket programs. And there is an increasing awareness of nurses. And my first introduction to the SEM Scanner was really being that specialist, running the gauntlet in the 008 study, the specialist versus technology. So there was immense pressure on me. I was the visual skin assessor, and I was dictating the care of those patients. Having said that, I wasn't there 24/7, so I could prescribe care, but I wasn't there to actually deliver that care. And then I wasn't also made privy to the deltas of the patients. So I didn't know what was happening under the skin, and there was immense pressure. So really, Ruth has talked to you about the results of that study, which shows that on average, you got a 5-day window of opportunity for those patients. And I think for me, one of the things that came out of that was it was an ability to engage with those patients on a one-to-one level, because patients were actually asking the scanning nurse what their delta was and what that meant for them. Should they move more? Could they move more? And, if you take that to the nth degree, it would allow nurses to operate in a very different way. So instead of implementing blanket programs, they could focus attention more on those patients that were having deviated SEM. So for me, reacting to red really is too late. And you will know more than I in some of your patient populations with non-Caucasian skins that reacting to red is very difficult because you don't actually see that on the external skin. So really, it's about acting at the earliest point. It's about being able to view and act before the damage so we can reverse that. So we can implement strategies to prevent pressure ulcers for the very first time in terms of making clinical choices which impact directly on the patient care. And what we know is that it is about getting it right. I have a lot of knowledge about the anatomy and physiology, the patient behaviours, risk assessment and equipment, and factors that I might take into consideration when doing somebody's Braden or Waterloo score that my colleagues wouldn't maybe take into account. A deteriorating picture, the patient's mobility being perhaps the biggest factor, as Tom brought out. But if the experienced nurse can't get it right, because we were site 12 in that slide that Ruth showed there, and we only recruited 10 patients, but we recruited those 10 patients. We were the last site to come on board, and we recruited 10 patients in a month. So, we did really well in terms of that. And then the study reached its final analysis. But if I can't get it right with my prescription and 2 of my 10 patients develop damage, what hope has the generalist got? So my questions to you really is, what we're doing now, is it good enough? Can we continue to have such litigation in the system? And if that detection can enable earlier targeted intervention, that surely will free resources. We're not getting more nurses. In the UK, we have a huge shortage of a nursing workforce. So if we can free resources and improve care, that cash release enables the purchase of these devices. So the opportunities I see for the scanner are that we can react before damage and target our interventions, encourage patients to use their own data and know their numbers. And I think it's really important that when opportunity knocks, we open the door, that we re-engage clinicians to think differently. We all often think that we do it well, and it's very hard to stand back and criticise ourselves. And the other question that I have for you is, this study was very much done, and most of the studies have been done in acute care. So what would the scanner look like in community care? And really the last part of this is my privilege to share with you the real world data. So like Martin said, when you get the kids home from that weekend away, all you can hope from your kids is that they're good when they're with strangers. But when they come home in that real world data. So this is just our data from a small evaluation in one of our orthopedic trauma wards. So the average length of stay for us there is 3 days. It's 27 bedded unit, and it has 19 single rooms. And NSEC just is an acronym for our Northumbria Specialist Emergency Care Hospital. So it is hugely criticised, this ward, for having high numbers of trust-acquired pressure ulcers, and there was a suspicion from the clinicians on the wards that a lot of patients had long lies and had damage prior to admission, but they weren't being scanned or ultrasounded. It was just visual skin assessment on admission. So this run chart really shows that this ward had 27 PUs that were hospital acquired within a year. The median was around 2 per month, and the max was 6 in January 17. The blue line there on that run chart shows that this ward, as a result of that, were enrolled in an academic health science regional collaborative to do PDSA cycles to see what they could do as a ward to reduce their pressure ulcers. So you can see there that started in April 17 and it ran right through October. So the initial excitement of being involved in that drove their pressure ulcer numbers down to 0. And one of the things that they did was implement a offloading heal strategy to do that. But you can see their numbers crept back up. And we then introduced the scanner in September of 17. And you can see their numbers then went down and consistently stayed down going through. So they scanned 52 patients during this evaluation. One patient had a deviated SEM detected on admission, went on to develop a category 3 pressure ulcer despite interventions, but the patient declined pressure relief and the pressure ulcer healed prior to discharge. 22 patients were discharged from Ward 1 with a deviated SEM. And the receiving wards and community settings didn't have the scanner. And one patient went on to develop a pressure ulcer to their sacrum and one to their heel. But it's very, what is clear here to me is that if those receiving wards had understood or had training on the use of the scanner, that we maybe could have prevented that damage. And of course, 2 patients passed away during the actual evaluation. And that is real world data in terms of what happens in trauma orthopedics with our elderly fractured neck of femur population in the UK. This next slide is perhaps one as food for thought. And it just shows, if you read up from the bottom, we call our DATEX reports our incident reporting. So nurses are encouraged to report any pressure ulcers that are admitted to the organisation. And tissue viability, my team look at all of these reports and we validate the pressure ulcers. So you can see there, we have had 280 incidents of injury, 212 which were categorised as 1 to 4. But interestingly, this top line here is what I was saying about the community care piece. 447 patients that were admitted to our facilities were admitted with a degree of damage already. So how could we be scanning these patients in their own home? And I think there is a huge opportunity here for us. So if you think about pressure ulcers, patients receiving care for pressure ulcers. In the UK, NHS England and NHS Improvement have a pressure ulcer productivity calculator. So this is just plugging that data into that calculator. So in my health economy, in the 6 months that I've given you data for, 958 patients were receiving care. And that pressure ulcer calculator shows a health economy cost of over 6 million UK pounds. But if we look at our trust-acquired injuries and look at the 212, taking out the 21 patients that at this time of data analysis were being investigated and not fully validated, and the 4 DTI that resolved, and the 43 IAD and MAS, moisture-associated skin damage, the health economy for us, of the ones that we could have prevented, was over £1 million. 1.3 million pounds in terms of the cost of treating those patients. So if we reduce that by 5%, we'd save 69k. If we reduce it by 25%, we'd save £347,000. So that's taking a very conservative approach, because if I remind you back to Tom's slide, he suggested that most facilities had made at least a 50% or upwards of 80 to 90% reduction in their figures. So this is the point that we're currently at. So we're looking at investment in the scanners and looking at 2 per ward, which would cost us about £200,000 plus VAT. And VAT is about 20% in the UK. That is a tiny figure, really, when we think about reducing patient suffering and harm. You know, these patients are living with a pressure ulcer that is painful, that extends their length of stay, and in the worst case scenario can result in death through sepsis. We are seeing, as we follow everything across the pond, an increase in litigation costs, nowhere near, nobody has been jailed yet in the UK, but nowhere near in terms of payouts that you would get in the States. But if we can reduce those litigation costs and reduce the operational costs, at that lower estimate, we would make savings of £127,000 in year one, despite that investment in the scanners. So I think there is a huge opportunity here. The opportunity is to act and do things differently, to reinvest, and to allow our nurses to focus care on those at much increased risk, and to act before we see the damage at the skin surface, which is too late. So I'd like to thank you for listening. Apologies for myself and my colleagues for running over, but at least you've had breakfast, which was provided on behalf of BBI. And if any of you do want to ask questions, my colleagues will be here, and you can ask them either with a roving mic if you want to stay with us for a few minutes longer, or the panel will be here at the front if you want to do a one-to-one type questioning. Thank you for listening. Oh, the scanners, if you want to touch and feel and play, are actually outside, and BBI have them, so they would very much like you to have a look at those devices.